morning.
How are you?
All right, and yourself?
Good. Did you
I
see
like the
the?
hair.
Oh, thank you. Thank you. Did you see the intro? Did you get a chance to? You never commented on the new intro. Do I need to send it to you individually so you can take a
I
look at
really think you do because I'm totally missing it.
it?
Oh my god.
Oh my God, sir. Yes, I'll have to send it to you individually. Wait, let me get
I'm
this better.
sorry. I
That's our. I'm like, oh my work. It got some little pictures, you laughing, all kinds of little stuff. Sir. Okay. Just bless my bubble. Okay. Okay. How's your week? How's your week?
it was busy, but I'm glad it went by quickly.
Yeah, yeah, it
How
was
about yours?
busy. It was busy until we got all this snow, and then everything shut down. I was like,
Oh
yeah. Who's not leaving the house? Me.
yeah.
And
well,
then
well,
we got vaccinations the other day. So my mom got three different ones, and I got three different ones. And so I was fine. I've done, I thought, well, we was babies, we was kids, they would shoot us up all the time. We'd be good. Mm-mm. My arms were so tight
really?
and so sore. I did my COVID um flu and shingles, the first thing of the shingles. Yes, I'm dating myself. Shingles. And so I was fine the first day, and I didn't take any pain relievers or Tylenol relief or anything. So I'll be fine. So I was okay. I woke up the next morning, so I get up early in the morning and I go walking, and I could barely walk. I said, "Why is my arms affecting my legs? What is happening?" I can't. So the people that I walk with, she was like, "Well, come on." I said, "No, no, you go. This gonna be a slow stroll today. I'm here, but I'm a stroll." But we got it in. We got it in. But yeah. And then my
Good.
mom, she didn't get out the bed all day. I said, "Ma'am, if you don't come eat, take medicine, do something, ma'am." But that was my week. But it was good. It rather I saw you at the happy hour. We had to talk
Mhm.
about our experiences in the
Yeah.
meeting after the meeting. So all good, all good. Okay, well, let's get, because I got a packed agenda today and I want to make sure we get everything in here. So welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, the weather, vaccinations, all of the things. Um, the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. We do appreciate that. That allows others to see and hear all this tea that we'll be spilling today. So, I am Clarice Warner. I'm the Girl with the Pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you really? Do you? Well, before I introduce my co host, let me share with you information on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right, all right. So if you are interested in receiving additional information about the 5 steps to become a certified marketable medical coder free email course, then check out the video description for the link. Yes, it's a lot of stuff in there, but I promise you it's there near the top. So joining me today is my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. I love it. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been a nurse for 3 decades. In 2014, I transitioned into HIM, and during the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other healthcare professionals with a clinical background transition into the wonderful world of HIM.
Hmm. And how is all of that working out?
It's coming along nicely.
Yes.
So I started to switch it up and use my HHS elevator pitch, but I was like, no, I ain't going to do it.
You better come with it. Look, those are some things we need to perfect. And hey, here's a space. Here's a space. You never know who may be watching.
I mean, because they come with it, don't they?
Come with it. I'm like,
And I was like, I need me some more set asides. I don't have enough numbers behind my name. 8A, 72B. I'm like, what?
I feel like the cat in the hat. I feel like I needed to rhyme and dance something. I'm like, what is oh my God. Oh my God. Oh, I can already see this meeting after the meeting is going to be hilarious. Okay. Because you done brought me to tears already. He's been here but 5 minutes. Okay. Oh, that is hilarious. So yes, I feel you. I had the big out like, wait a minute, I only missed one. I just missed one. What has happened? The time that I just missed one. Oh, it's a whole new ball game out here these days.
Yeah.
Okay. Good morning, Vicki. Good morning. Thanks for joining. Okay, so hilarious. Well, let's get into before we get into everything, let me remind you that this is a conversation, and so we want you to feel free to add to the conversation. You can jump into the comments, throw your jokes out there, get into the funny of it all. We like those too. But also, if you have questions, just type a Q first so that we know you have a question. And don't be shy. Your opinion matters and is welcomed here, even if it's different than ours or mine or his or whomever. Feel free to put it out there. It's okay. We family. Okay. So for those who are joining us or watching the replay, today we are going beyond the charts and talking about Medicare Billing Vigilance, CEO exclusions, Lord, legal twist, and coding connections. But first, let us get into our church announcements. Oh, goodness. So as we humble ourselves to go before the church announcement world. When I did my motivating Monday message, I swear I started to put my fan up in the background like, hey, because I talk Martin Luther King, but yeah. And I still owe you your little care package with fans and all those things, so I'll get that out to you still. But anyway, so this week in the world of church announcements, let me just say, first and foremost, if you check your state, if you're a HEMA member, check your state, because a lot of states have now adopted a petition to sign on if you are against the 40% education requirement coming from a HEMA. So you can check your state. You can log on to OHEMA, which is Ohio. We have ours. I think I've seen Nevada. I think I've seen
Pennsylvania too.
Pennsylvania got theirs. I want to say Tennessee. I don't want to call out folks and they don't have none, and I'll be out messed up. But I know there are several states out there that now has that. So if you are opposed to it and want a additional way to make your voice heard, then here's an opportunity. Please feel free and sign up the petition. Last thing, in Ohio, y'all know what time it is. It is voting time. It is time to vote in your leadership. So use the power of your vote to show your voice in who you want to lead you going forward. I, as the current president of OHIMA, would love to see our voting numbers just pop off the charts. So I am recommending that you take a look at your candidates, get to know them, check them out, see what they have done, what they're preparing to do, all of the things. But do exercise your right to vote and vote in the election. I think you have until the end of this month to do so. The other church announcement I had was from the AMA. One of the things that they mentioned, and this is a public health announcement, they're saying that there have been an increase in new cancer cases to more than 2 million in 2023. That's a lot. Things have been on a different trajectory, and for whatever reason, things are going the opposite way. They said cancer deaths are falling, but the cases of new cancers are on the rise. So just wanted to make sure folks were aware. The increase are for breast cancer, prostate cancer, melanoma, kidney, pancreas, and uterine. And lung, colorectal, and pancreas cancers actually cause the most death. And among younger than 50, colorectal cancer has become the leading cause of cancer death in men and the second leading cause in women behind breast cancer. So please get your screenings. Please, when something doesn't feel right or anything with your body, please go get it checked out. Early detection, early, even prevention helps save lives. So please be mindful of that. The other thing is me being the vegetarian that I am. A diet rich in plant protein may help women stay healthier as they age. Look at this auntie over here. So there was a study that says a diet rich in plant protein, or it says protein, but it's especially plant protein, may keep women healthier as they age. The studies found that each 3% increase in the amount of plant protein consumed was associated with a 38% higher likelihood of staying healthy as the women got older, meaning fewer or no chronic diseases, better physical mobility, and little cognitive decline. So yeah, so feel free to join us over here and I'm not knocking the carnivores or anything like that, but incorporate maybe once a week what they call it, meatless Monday or something, where you just do a plant-based diet for a day. Just try it, see if you like it. You need some recipes, holler at your girl, I got some. All right, so those are my church announcements. Mr. Jesse, do you have anything?
I wanted to mention that the Crafty Coder said Florida has a petition as well.
Oh, okay. Thank you, because I couldn't see her and all the stuff that's going on. All right. Oh, thank you. You say cute hair. Thank you. Y'all know I had to do the old school church auntie rollers. That's all I did.
Okay.
Okay. All right. So. All right. So, when I say I was doing the research for the stuff for this show, and I said, well, excuse me, what in the world is going on? So this first section on Medicare billing is for, again, for the billers. So if you are a biller out here in these streets running reckless and wild, and we done talked about y'all, or pretending to be, yeah, let me let that go. But where's my tea? Hold on. This one is for you. Now, if you are billing for Medicare, Medicare got rules. Hopefully,
A bunch
y'all know
of them.
that by now. Huh?
A bunch of them.
A bunch of them. Medicare has rules. And Medicare really, they don't play about their rules. And they tell you these rules. They give you advance notice. They let you know, hey, these are rules. These are things that um, are required. Now, one of the things that Medicare is telling these providers that um, protecting PHA is the responsibility of the provider. So if you, provider, choose to outsource your billing function, and your billing people are out here running rogue, or other outsourced agencies, I won't beat up on billers, but I guess I will. Other outsourced agencies, um, you, my friend, would be the one responsible for what's happening. So CMS has some mandated systems that requires all providers, billing companies, and outsourced agencies to use. Requires. It's mandated. Can I say them again? Requires. It's mandated. One of them is the interactive voice response system. And then your MAC, or Medicare Administrative Contractor, has what's called an e-services tool. Now, these tools help you check eligibility and claim status. These are the tools that you are supposed to use. But CMS have noticed that these outsourced business associates are not adhering to these requirements, and it's a mess out here in these streets. One of the MACs, particularly Palmetto, and this was an article. This article came from the Knowledge Center from AAPC. It's from Lee, I think Byfield is. I hope I hate to butcher people's name, but I think that's the last name. Anyway, want to give them their props on providing us with this information today. But it says that Palmetto reported that it had seen an increase in inquiries from billing companies and other outsourced agencies that have failed and even refused to use one of CMS's mandated automated systems. And then they have also been seeing increases in calls from representatives who are not familiar with basic Medicare coverage or billing requirements, necessitating, get it out, repeated explanations and MAC guidance. So basically, they trying to tell y'all, we shouldn't be teaching your billing people the billing rules and regulations. They should know. They should come to the table saying, hey, well, we understand, da 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 da, but we have this individual case of such and such and such. What do we need to do? Versus, can you tell us what adding this supposed to mean? Y'all messing it up out here in these streets. So if you provider group, provider entity, whoever, has these outsourced billing companies or other outsourced entities, just make sure that be careful. Be careful in these streets. You don't want to get tapped on your shoulder because of the outsourcing that you have going on. They're warning. Shots fired. This was a warning shot. They're telling you it's up to providers to confirm that their vendors are following proper channels of communication and understand and follow Medicare requirements. Verifying that adequate processes are in place is crucial, If the vendor is deficient in their work, it is the provider who is held accountable for any protected health information or HIPAA breaches, not the outsourcing agency or billing company. If a PHI disclosure were to occur, the provider would assume full responsibility, including all financial penalties. Y'all better get y'all stuff in order. That's fine. They also recommend you can help them by making sure you are providing your vendor with access to the Medicare remittance and appeal notices for services and claims they will be working on, and that your vendors have knowledgeable staff, are aware of and following Medicare rules and regulations, and are using resources available on, and again, since this was Palmetto, their website as well as CMS's website, and understand the requirement and will or are using the available IVR and e-services tools to verify eligibility and claim status. So yeah, they putting folks all on blast. Mr. Jesse, did you have anything for that?
Well, you know, we first I wanted to say good morning to Renita,
Good morning.
but you know, we have been talking about outsourcing forever and 3 days, and I just I just don't know what else needs to be said, how many more examples they need, but you know, it is what it is.
It is, and it just, I don't know. You know, we talked about folks just got to do their homework. They got to do their due diligence. They have to vet these people, just like we talk about students vetting the education programs or services that they're looking for as it relates to getting their coding education and all of those things. Providers need to do the same. Also, providers need to, I don't even know how to get to them, but providers just need to know that there's a whole world outside of what you do as a provider. And while it may not be in your wheelhouse to be knowledgeable about all of those things, on that claim form, when you send it to a federal payer, you are attesting. You ain't, there is no wet signature. It is an electronic signature that is in whatever system that you use that states when you send it over there to them that you are attesting that everything is what it's supposed to be. Period. That's why you are responsible. Now, eventually, it'll trickle down and get to whoever it needs to get to. However, ultimately, first and foremost, the provider who provided the service and submitted the bill for the service that they said they provided is ultimately responsible. Y'all gotta know this. So it's on you to make sure that the people that are handling the playing with the church money know how to play with the church money and know the rules and regs and what's happening with playing with the church money. And that's billing, that's coding, that's compliance. That's all revenue cycle things. All of the revenue cycle things. Make sure folks know what they're doing, because you know it's easy to be like, oh, I read something and I heard something and now I'm the expert. Really though? Okay. Because they come in every industry. You got 5 minutes of knowledge and here you go. I just felt 5 minutes of fuck real quick.
People know just enough to be dangerous.
Just enough, but will argue you down that they know it all. Bless their whole entire hearts. Okay. So that one was that. Next, we got CEO exclusions. When I tell you I clutched my pearls, and I don't usually clutch the pearls too often, but I clutched the pearls. So way back in the day, Theranos, I hope I'm saying this right, is an organization that I think I got some information on them. They provide um uh, healthcare devices, technology, all kinds of stuff in healthcare. And in January of 2022, the CEO, Elizabeth Holmes, was convicted for wire fraud and conspiracy to commit wire fraud against the Reynos investors. Um, the the usually the statutory minimum for an exclusion based on convictions like Holmes is 5 years. When certain aggravating factors, and this came from the notice the OIG issued the other day. When certain aggravating factors are present, a longer period of exclusion is justified. The length of Holmes' exclusion is based on the application of several aggravating factors, including the length of time the acts were committed, incarceration, and the amount of restitution ordered to be paid. Let me just go back. Elizabeth Holmes has now been excluded from participation in federal health care programs for 90 years. 90, 90. That's like forever. They just should have been like indefinitely. 90 years. Um, she was sentenced in May 2023 to 11 years in federal prison, ordered to pay approximately $452 million in restitution due to her offense resulting in a significant financial loss to entities and adverse financial impact to other individuals. So she founded the Reynos in 2003 and served as its CEO and chairperson. And under her direction, the Reynos claimed to have developed proprietary technology that was able to run several clinical diagnostic tests on small amounts of blood from a finger prick instead of through um, venous draw. During her trial, the government presented evidence that Holmes knew the Theranos device was never able to complete more than a small number of blood tests, and the results were less accurate than traditional or conventional blood testing machines. Holmes' false claims about Theranos induced investors to provide millions of dollars in funding, and in two instances to develop plans to partner with the company so that the Theranos technology could be made available to provide healthcare services to their customers and patients. So she's out here in these streets just doing the things. HHS and the OIG also previously excluded the Theranos president, Ramesh Balwani, for 90 years as well, because he was also convicted for conspiracy to commit wire fraud against the Reynos patients and investors. Yeah, they not playing out here in these OIG streets. Here we it. When I tell you, when I saw that 90 years, I said again, I clutched my 90 years.
But I just wanted to jump in. Like, this was a much bigger deal than what people are. This woman, Elizabeth Holmes, was on the cover of Time magazine.
She was doing balling
Like,
out here balling.
so I think that's why they really threw the book at her, because the level of deception was next. It was epic, and she had them going.
I'm gonna wait for the Netflix special because I know it's coming.
Yeah, it was that big. Like, she had them fooled.
Wow. Just wow. Folks out here. That's how I like. Folks
Yeah.
are out here.
And I still remember the Time magazine, the cover. Like, it's a picture of her holding this little pill.
Mm-hmm. Mm. Well, at some point, you can't fool everybody all of the time. And you got. Okay. Next, we want to talk about these legal hurdles. This one right here is an article from an attorney, Nicole Emanuel. And it
I
says,
follow. You know, she has a blog. I follow her.
she's part of the rack monitor team that I follow as well. Yeah, and she's good. Um, she's good. I think there was one or two times I was like, ma'am, but for the most part, I love her, the information that she provides and her.
Before you go on, because she had told me this was maybe 3 years, 2, 3. It was a while ago. She told me because I was like, how do you find out these these people who are on prepayment for Medicare, Medicaid? And actually, she told me that you can do an FOI request from CMS, and she told me how to do it. I was like, okay, thank you, Cole.
Nice, nice. That's good information.
Mm-hmm.
We need to talk
That's
more
true.
about that. We need to explore more about that in the meeting after meeting. Because that's some good information right there.
All you got to do is you could even email right to CMS right in Baltimore. Well, Woodlawn.
Okay. Okay. All right. Yes, yes, yes. Okay,
All right,
Nicole.
continue. I ain't want to segue, but I
No, but
do.
look, I said I'm putting a pin right here because we need to follow up in the meeting after the meeting. Okay. Now, so in her article, and this is true, she says that um, we've all heard, how the OIG or the insurance companies, everybody has had these instances of uh, what to do, what not to do when it comes to billing for evaluation and management services. There is oftentimes a fine line between one level to another level, and understanding what that means. I personally love evaluation and management. It has been my area of specialty for years and years and years and years. Um, so when I saw this, I was all in. I was all in. Like, okay, you caught me with the first thing. And then that these um, definitions, the AMA has come out and they have reframed and redefined the qualifications on how you provide the leveling for evaluation and management services. They started in 2021. They're still kind of trickling things in. Even in 2024, there have been some additional changes to evaluation and management. Again, you're looking at two ways. You can either base it on your medical decision making, or you can base it on time. So,
Clarice, I'm hearing a little static when you're talking.
okay, because I can't hear you at all. Is it a lot of static? Do I sound like? Look, I sound like you sound.
I can make out what you're saying, but it's just like
Okay. Can you hear me? Still me?
every time you talk, I hear it.
Oh, every time I talk. Okay.
Now, see, I hear it. Yeah,
You hear it just being on. Maybe is that better? Because I don't have
it's
my whole system
oh,
up
that's
here.
better. That's better.
That's better. Okay.
Yeah.
Okay. But can you still hear me?
I can still hear you. Yeah.
Okay. Okay. Maybe just up here. All right. So, um, so she says she there is some subjectivity in assessing whether a moderate or high level of decision making has occurred. Um, One of the definitions allow physicians to rely on time spent with the patient, but it doesn't necessarily state is that equal to face-to-face time. The definition does not specify face-to-face time. And in her opinion, she does not believe that the time requirements necessitate only face-to-face time. I thought so again, this leads to a little slither of a door opening as it relates to patients. So again, one person's determination that a 99205 occurred could be the next person's 99204. Despite the obvious subjectivity, courts have convicted physicians of healthcare fraud for billing 99205 instead of 99204 or 99206. What happened in this case, there was a conviction of a Maryland physician for his role in a $15 million Medicare fraud scheme. And what happened was over the holidays, this week, his case was vacated. It was overturned. A federal jury in Maryland had convicted Ron Helfenbein, who's 49 years old, of Arnold, Maryland, for 5 counts of healthcare fraud for submitting over $15 million in false and fraudulent claims to Medicare and other insurers for patients who received COVID-19 tests at sites operated by the defendant in August 2023. Dr. Effenbein was the first doctor convicted at trial by the U.S. Department of Justice for healthcare fraud in billing for office visits in connection with patients seeking COVID tests, which makes his acquittal even more important for other providers across the country. This is going to be that case law case that folks are going to actually use. You still hear the static? Do you still hear the static?
I can still hear it, but it's not as loud as before.
You still hear me?
Uh-huh.
Okay. Okay. I don't hear. I can't hear me. Okay. I'm trying to listen. But anyway, she said this is going to be one of those groundbreaking things because all providers need to understand and use this information in their defense if they're ever put in a similar position. So his conviction was based upon his billing of level 4 E&M claims for patients receiving COVID-19 tests, which the Department of Justice determined was improper use of the billing codes. According to the evidence that was presented at his 3-week trial, he instructed his employees that in addition to billing for the COVID-19 test, they were to bill for E&M visits. In reality, these visits were not provided to patients as represented. Rather, Effenbein instructed his employees that the patients were, quote, there for one reason only, to be tested, end quote, and that it was, quote, simple and straightforward, end quote, and that the providers were, quote, not there to solve complex medical issues, end quote. So he faced a maximum sentence of 10 years in federal prison for each of the 5 counts of healthcare fraud, which he was convicted. So his motion for acquittal, which was granted on December 21st by the same federal judge who oversaw his initial trial, found that because E&M code, the E&M CPT codes, again, the type of medical billing codes that Dr. Effenbein used, are imprecise and designed to allow, quote, physicians flexibility to exercise their best judgment given the multitude of factors that go into medical decision making, end quote. His use of the higher cost level 4 codes did apply to the patient encounters based on the relevant guidelines. In a detailed 90-page ruling, James K. Rader, who is the chief judge of the U.S. District Court for Maryland, said the government did not meet the bar to convict Dr. Ron Elfenbein and ruled that imprecision does not necessarily integrate well with the clear notice and due process guarantees of our criminal law. And where the relevant CPT codes and related definitions are ambiguous and subject to multiple interpretations, problems clearly arise. She said she agreed. Ambiguous or subjective rules should not be the basis for criminal penalties. Civil penalties, possible, because I still feel there's somebody playing with the church's money, but not criminal. Okay, hopefully y'all
But
heard that through the steps.
I did hear that. But here's where it is for me. We all know that this is the definition of fraud is intent.
Intense.
This man intentionally, because
Intentionally.
we I'm sorry, like there is nothing ambiguous about coming in for a singular test versus a level 4 CPT code. I'm like, I don't know what kind of attorney this man had. I don't know what kind of dirt they had on that judge, but this is crazy to me.
Crazy. Crazy. So on one hand, I see why, everybody would be rah-rah, but on the other hand, when you read the facts of the case, it's clear to me. I feel like Stevie Wonder, Ray Charles, everybody could see what he said, which this is the only reason why they coming in. That's to be tested. We ain't doing any kind of complex medical issues. We're not solving anything. We're not treating anything. Where is the meat here? Everything is simple and straightforward. I don't know. I don't know.
What I do know is they better be glad that this ruling came out after that 365-day billing period, because had this happened when providers could rebill, oh, it would have been a whole lot of doctors rebilling on Monday to get that extra money. That's crazy.
Crazy. Oh yeah, he had an award-winning attorney. Oh, he had somebody. He had somebody in his back pocket. Okay. I said, oh my, oh my, oh my. But
I mean, I don't think. I mean, a level 4, like there is, and how do you? What is ambiguous about a level 4? Like it tells you what the criteria is.
I don't know. The more I read this, the more I'm seeing some additional holes um, in this. But I'm not an attorney, and I don't even play one on TV. But to me, I wouldn't even say it's an open and shut case. I'm trying to understand how. I think they're two different things rolling here, because the ambiguousness of the codes, what do they have to do with the intent of this physician? And we just gonna apply an E&M code with every COVID test that we do. It don't matter if the code is ambiguous or not. The E&M code shouldn't have been applied because you didn't do anything for an E&M service at that level of code.
At that level, because where are the notes for these encounters? That's what I would like to say.
Where are the notes? What do they look like? That's a whole other thing, because clearly forget, and even if you quote unquote, which it appears that they probably use time, you can't use the time of the service that you provide. That's not it. That's not the jam. But then if you got documents and witness testimony and statements and all of the things that clearly quoted what he said to his staff, I don't know. I don't know. This one looking a little foolish.
It is. I mean, because even and like you always say in the meetings after the meeting, like if you use time, can we be very clear? $15 million. That's a lot of COVID tests.
That's a lot of COVID
And
tests.
if you're using time, were you doing round the clock testing?
That's all he was doing. How do you see your other patients? Sir, did you have other patients? Did you see him at all? I don't know. I don't know. No, people send in, I can't understand, and not even reviewing the notes. So there's that. But at this particular level, notes should have been reviewed. I mean, this has gone to the they're in the trial. This is the Department of Justice. They're definitely, you got to have all kinds of evidence when you at this particular level. So somebody should have been reviewing. And if y'all needed somebody to review, I'll let your girl. I could
Because
have. This was an open and shut, easy kind of
because
thing.
what I'm thinking is, if it's that, moving forward, how is the OIG going to prosecute anybody if these um guidelines are so ambiguous? How are they going to do that?
Because they're all ambiguous. They're all gray. They're all gray. Usually. Especially in evaluation. Let me just say that. In evaluation management. They have been gray since inception. However, to your point, the definition of fraud is real clear. And it's about your intention. And clearly, you intended to defraud if
Yes, he
you are
did.
adding a service that you did not provide on top of a service that you did. I don't know how. I don't know. I don't.
Because
Somebody
everybody,
help me understand.
right? Because I mean, everybody knows that somebody can come in for COVID testing, and you can they can have a thorough visit, but the documentation has to support that. You have to
Exactly.
show where you went over and
Clearly.
above just testing. That's
Clearly.
and then it has to meet the level to which you said you build.
Clearly. And don't forget the overarching uh, character in this is the medical necessity. What is the medically necessary reason to have an E&M service when you're giving a coding vaccine? I know things was a little different back in when we were hit in the COVID pandemic and people were panicking and all kinds of stuff. But and some rules were relaxed. But that wasn't one. That wasn't one.
And they were depending on the
Let
type of
me
test.
refiling my stuff right now.
I mean, and depending on the type of test that they were doing, the government was generous with the payment amount. They weren't all right. They weren't all like $38.
I don't know. I don't know. I don't know why. I don't know. I love the law. I do. I swear I do. But I don't know. There may be some stuff going on behind the scenes. Maybe they about to catch me for
Clearly,
something bigger. I don't know. But this one right here, this one right here. Okay. Moving on.
yes.
And then the last thing, Dr. Erica Reamer, and she has, I met her. She did we met virtually actually. She was one of the presenters at our Ohio State trade show and annual meeting, and I worked her virtual room, and so I got a chance to see her in person do her thing. Well, she has a webcast that's called Ask Dr. Reamer, and she does it several times a year, and folks, not only coders, but professional or the providers also reach out to her and ask them things. So she put together several an article that talked about several questions that she had, but one caught my eye. And well, actually two, because there was one regarding a sickle cell patient. I stopped being cold, like, whoa. But the one that I wanted to talk about today was hypertensive heart and or chronic kidney disease. I know these are your favorite. We right here in your wheelhouse, sir. So She said a provider bemoaned the fact that coders use it as the principal diagnosis, which is affecting their institution's heart failure readmission metrics, and they wanted to know how to avoid this. So she says, it has been my observation that many providers are only familiar with I-10, essential hypertension, and they are not aware that there are entire other code sets dealing with hypertension in the context of heart disease or chronic kidney disease. Good coders know that there is a presumption that that heart failure in a patient with hypertension should be coded with an I-11 or I-13 ICD-10 code. CM code, ICD-10 CM code. She explained that it isn't due to the quote with convention. The converse is true. The reason the quote with convention applies is because these conditions are so frequently linked clinically that the association can be assumed. And that is why the title has quote with in it. Providers should think in it. We've heard that a million times. We've said it before. Everybody has said it. You're supposed to write down what you're thinking so folks can know and follow your train of thought. Providers. Anyway, if they do not think that hypertension is the reason for the heart failure or chronic kidney disease, they should link those conditions with the alternate cause. Also, if they think some other disease process after study was the condition that occasioned the admission to the hospital, they should document that explicitly. Feel free to check out. Oh, now she's going to her other thing. So I just that right there was piqued my interest and curiosity because as coders, we will, as she stated, as good coders, we all know what the guidelines say, because this is really a guideline issue all day
All
long.
day. That's
What
right.
the guidelines say and what the coding conventions in your book says on how to appropriately code this. To her point, these providers don't know that. To our point, the providers shouldn't have to know that. They just need to be trained appropriately on documentation. So again, the documentation is what we use. It's all we have to do the jobs that we are supposed to do. It is the provider's job to, of course, provide whatever service and document such services appropriately. In your world, Mr. Jeffrey, in the CDI world, here is to me, a classic case of the importance of once you submit that query and once you get that information corrected, if you will, the next steps need to follow, and that's education. There's a clear gap here in education. Again, do the doctors need to know that all of these guidelines exist and all that? No, but what they do need to know is that they need to document. And let's talk about just plain simple documentation 101. Mr. Jesse.
Okay, so this I do agree with education, but I don't believe that they should that people should educate providers on how to. They need to work on documentation, but so many times, especially in outpatient, they want providers to pick codes. If you do not have the codes um, worded correctly in your encoder, you can shoot yourself in the foot. For instance, there are some, if you like, there are some encoders when they pick the code, it'll say, or the provider will say type 2 diabetes due to CKD. If that provider says that it's due to CKD, then you can't, then when you use E11.22, you can't use I12.9 because they are linking the CKD solely to diabetes. But if they just link hypertension, CKD, and diabetes, then you get to use both combination codes.
Mm-hmm.
So unless you're going to do some sure enough education and constantly reinforcing and work on it. Because I've seen encoders where these not encoders but the EMR systems where it says type 2 diabetes due to CKD, or CKD due to type 2 diabetes. It's like they pigeonhole themselves. And from a risk adjustment standpoint, that's not a good thing. And also a from a practical standpoint, it's not good because I have seen it, not too often, but I have seen it where a provider will say that the CKD is due to hypertension and diabetes. That's
Mm.
somebody who's clearly been educated. And that's a good thing if you're going to do it. If you're going to document, then you have to document. But otherwise, you just have to. I just think that I don't know. And I do agree with the crafty coders comment about encoders. Honestly, if it wasn't for some of these encoders, I think the coding would be worse because at least they give you something to think about. Because these people, I'm
They
telling you,
throwing
been
somebody a clue, a line, or something.
exactly. And also but it also, but you have to know the guidelines because I've been
Yes.
because I've been talking about this at my job for a year. Our encoder, the auto suggested code, if somebody has unspecified CKD in the tabular index in the back of the book, you cannot use E11.22 for unspecified CKD. You have to have a named stage. For hypertension, you can use an unspecified CKD code. But if they just say AKI on CKD and they have diabetes, you better believe E11.22 is going to be a choice. But you have to know
Know
that
that.
you can't use it.
Yep. And so I agree 100%. I think also to your point, not only should there be some provider education on documentation and the coder or whoever, I think that's where your physician liaison or whoever needs to come into play, and they need to be that peer to peer having those discussions, particularly around um, cases where this this affects the church's money. It can affect, like you said, risk adjustment. It can affect your MSDRGs. It can affect all of them things. So those folks need to be having those conversations. But then I also agree that, and to your point, there needs to be some coding education here too. Clearly, um, folks jump into our profession in medical coding. We have said this. Uh, I know I have said it, and I know you have said it, and I'm sure other folks have said it and or heard it. This is a lifelong learning. You can't just say, "Oh, I studied, I learned, I took a test, I passed it, I got a job, and that's it." No, this stuff goes on and on and on and on. Why do you think we have quarterly coding clinics? Why do you think we have regular CPT assistants? Because the questions come up, things come up that need to be further clarified. Yes, we got a guideline, we got a rule, we got whatever, but then you got these other entities as well, because your insurance payers and your federal government payers, they got rules too. They don't always meet and match at the same thing. But you got to follow the rules you supposed to follow in order to code it appropriately. Period. And you got to know them and you got to stay on top of them. You can't just say, "Oh, well, I saw that one day." No, you got to stay in the trenches. And encoders don't foster that level of to me, in my experience, encoders don't foster that level of appreciation for guidelines. Yeah, you got to dig and you got to look, but you got so many other factors going on because you got productivity and you got this and you got that, that it doesn't allow you the opportunity to get the constant education and knowledge base that you need to have to do your job. Sometimes you got to take that home on your own and maybe read a book. I don't know, but you know, I don't know. But I think this is a gap in knowledge on both sides. I'm not pointing the finger one way or the other, but You got to know the role you play, and what your responsibilities are as it relates to that. I think.
I totally agree.
Yeah. Whew. We got it all in. Yay. We got it all in. All right, all right. Mr. Jesse, any closing thoughts, any final words?
No, this was good. We covered a lot of territory
We covered a
today.
lot of territory. Yes. And I agree. I buy coding books to ensure I still know how to use them. Amen, amen, and amen. Because when I tell you, I learned I'm my um video next week is going to be about there's new radiology codes. And so I was in there and I'm looking and I'm like, oh, wait a minute, hold up. I happen to, because I used to always go through, and I haven't had my first class of the year. So let me just start there. Haven't had my first class of the year. So normally, I make sure I go through conventions. I'm looking at symbols. There's a new little symbol in my CPT book that I ain't never seen before. I said, what is this? So things will come slip by you. And especially if you're niche to a particular specialty, sometimes the other stuff you'd be like, I don't see that, I don't know. So you don't know. But then something may happen, Lord forbid, the way they doing these quiet firings, that you may have to, readjust to a different position or whatever. Well, now you need to know. So it's good to just stay in a know. Be ready, stay ready, so you don't have to get ready. That should be the theme of this episode.
Yep.
Yay, she said some good tea with static and all.
Look,
I can't
and,
stand y'all.
and
I
believe it or not,
know.
now the static is gone. It's clear.
See, I don't understand. I don't understand. What is going on? She said, plus books are a write off. Join the meeting after the meeting. Yeah. Man, it's tax time. Let's talk about it. Absolutely. Absolutely. I don't know what happened with the static. Hopefully, it won't be too bad with the replay. Now I feel bad. But anyway, okay. Hopefully, it is what it is. I can't control all those things. I can control a lot of things, y'all. Y'all know I try.
Because I want to say one. I want to say one thing about the
Say
encoder.
it.
The encoder, in my opinion, the encoder sucks for ICD-10 CM, but for PCS, it's everything
Mm-hmm.
because you don't have to have the whole code. You can just put in a partial, and it will give you the table. You build it from the table. I'm
Yes.
like, I love it, but for ICD, I don't use it for diagnosis because if you put in the wrong keyword or you click on the wrong thing, it takes you down a rabbit hole, and you gotta by the time you do all that clicking and looking, you could have just used the book and got the code,
Yes. I
in my
agree.
opinion.
I agree. I think, which brings me to something else that we can further discuss later. With the changes in from ICD-10 CM to ICD-11 and how they're designing it, kind of similar to a database table kind of construction. So I think that in and of itself could potentially help these um, encoder developer folks in putting together a more robust product. However, you still got the piece with the guidelines and knowing where to go and to get the guidelines and all of that. Maybe it's me rubbing up against this. I don't know. All the guidelines and all of the things related to that. So I don't know. Interesting. Interesting. But I like you. I'm like, because of the table format, it makes the encoder easier. And you're kind of you're kind of limited. You only got so many choices once you get to the certain area, and then it's either this. Versus your diagnosis, there are multiple thousands, hundreds of thousands of choices depending on where you're coding and what's going on. So that may be some of the rub to it
And
as well.
well, I think another problem with the encoder on the CM part is they try to do too much at one time because if you want to code like a poisoning, you can come up with like three codes. Just give me the code for the poison, and then let me go back into the other. I know what they're trying to do, but it just creates a problem, in my
Yes.
opinion.
So they're trying to be predictive and
Right.
saying, okay, well, here's the poisoning, but don't forget you also need to put this
Right.
code or think about this situation or scenario or whatever. When just let me code. Let me be
Thank
great.
you. Just give me what
Just
I
let
asked
me
for
give me what I asked for.
and let it go.
But to your point, you said some of this encoder is helping some of these coders who probably wouldn't even thought of, well, maybe you need this additional
Oh,
what.
because all I'm going to say is this: like when the company I work for did, when our client had a breach, and they were talking about using the not the full on version of 3M, they were going to use the 3M standalone that didn't have, and they didn't have auto suggested codes, baby.
A revolt was
I see. I was here for it because see that law. I was back in the day. I mean, this is my first time using an encoder. I've been using the book for years. I know that stuff inside out. I'm good with a book.
30 years in, 30 years
So
in. I'm right there with you. Nobody is playing.
I wasn't stunting it. I'm like, bring it on.
Bring it on. We ready. Yes.
Yeah.
Yes, we ready. Okay, I'm sorry. Anyway, thank you all again for joining the Saturday morning tea or checking out the replay. Was the tea spilled today? Then some, I think,
Yes.
and then some. If this
Yeah.
information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Also, be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. As you leave, don't forget to hit the thumbs up or like button, or also slide in a comment. Let us know where you checking in from. We love to see our reach. Also, don't forget to check out the Coding Nurse channel on YouTube. This has been a great session today. Thank you all. Thank you all. For our Patreon members, don't forget we will be coming on into the meeting after meeting at 10:15. So we will see you there. Again, thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Be safe out here and stay warm.
Yeah.